So in that way, by bringing the tip of the tongue to play with that little tag, what you are doing is bringing the dorsum of the tongue to a more physiological position. And by bringing the dorsum of the tongue, you are permitting that the hyoid bone moves forward and downward, and in that way relaxing the anterior digastric. And in that effect, the mandible is going to stop rotating, and it's going to permit an anterior rotation instead of a posterior rotation. Okay? So that's one of the effects of and you can close the bite. So basically, by that effect, you can come from this situation to this situation. And use a little trick for those who work with cephalometry. If you want to start evaluating this effect in your patients, you just measure the gonial angle, all right? Remember, the gonial angle is approximately 130 degrees, okay? If you take the gonial point and just draw a line, gonial-nation, you are going to divide that gonial angle in superior and inferior. Normally, the superior angle is going to be around 55. The inferior angle is going to be around 75. That was reported by Jarabak. All right? So, if you have, for example, an open bite with an inferior angle, like this case, that I don't have the measurements here, but I remember the measurements, we have this inferior angle approximately around 80 degrees. And by the end of the treatment, it was in 76. So it means that the mandible rotate, the body of the mandible rotate. So in that way, we can understand that effect. And that's why now I have the answer why in 2004, USUMES was reporting that this angle was reducing because there is an effect of mandibular rotation. And that effect has been reported in the literature for the Frankel FR2, for the Simoes Network 2, and for the trainers. Those are the only three appliances that I have seen in the literature reporting that is an effect of mandibular rotation. And one of the things that I always talk is the position of the teeth is a consequence of what's going around. If you see in this patient something that was also interesting for me, look this lateral incisor. If I want to go through here, but I don't have room to go because I am this wide and I don't have room to go, what I can do is do this and do this, and I can go through, all right? That's what the lateral was doing. It didn't have room, and it was rotating to get into the mouth, all right? What happened when we produced transverse development? That tooth was trying to enter, didn't have room. Oh, now I have more room. I don't need to rotate. And the rotation was, I didn't put a brace. I didn't put a bracket in there. It was use natural rotation because we open the space and the lateral say, oh, I was going this way, but now I have room. I can enter. So give the mouth the opportunity to work, and it was going to respond wonderful. All right? So this is proving that in this case, we close the bite, but also we produce a transverse development, and now the lateral incisor is entering. Okay? So we are working a lot to produce research to continue proving all these situations and to proving the effect on soft tissue dysfunction. But always remember, this is a consequence of what's going here. Look at the breathing, look at the TMJ, look at the tongue position, look the activity of the masticatory muscles, look the facial muscles, look the supra and infraoid muscles, look the shape of your jaws, and look at the cervical position of the spine. And what's going here is going to be reflected here. If you correct and you bring all this to a physiological situation, this is going to respond and your teeth are going to be positioned in a very nice way. Don't work on the other side. So when is it possible to start treating a malocclusion? When a dysfunction in the craniocervical mandibular system or a malocclusion is diagnosed, regardless the age. So I can start working early. And this is a little patient that if you see there is a sign yelling me a malocclusion is developing. This patient has not only an open bite, a 3 years old little girl, beautiful girl, but she's opening the bite. She's yelling me, I am starting a tongue thrusting, I am opening my bite, and worse, if you check the shape of the maxilla is narrowing. Why the maxilla is narrowing? Because every time she is producing a tongue thrust, all the muscles are pushing inward. And remember that I told you that approximately here you have 2 grams per square centimeter, and when this is hyperactive, you have 20 grams per square centimeter, all right? I know that I gave you that information last night, but I didn't tell something else. Here, on the orbicularis oris, you have the buccinators and the orbicularis oris working together here at the corner of the mouth. When this is increasing, this can go even up to 80 grams per square centimeter. So what it's doing to the mandible, to the maxilla, is narrowing and triangling, making a triangle on the maxilla. That is happening in this little girl. All right? So I need to start treating this patient. And the first thing that she was doing is thumb sucking. So I cannot give an appliance to her until I control the habit. Because if I give an appliance to her and she is totally used to the thumb sucking, she's going to take the appliance out and she's going to put the finger in the mouth. So one of the tricks that I use is that I use this coffee stirrer stick, the coffee stirrer, just a little tube. I cut to the size of the thumb, and I just tape it. And I tell the patient, you can suck your thumb whenever you want, as long as you want. Your parents are not allowed to say a single word. You have my permission. If they say something, you say, my friend Herman, tell me that I can do it. If they say something, you come to me, I am going to punish them. I am going to ground them. All right? I am always on the kid's side. Okay? And when do you suck your thumb? When you are at home, so you need to use it at home. So every single time that you are at home, every single minute, you have to have this little thing in your finger, on your finger, all right? Do you suck at the school? No. They don't show at the school that they suck. Some of them say yes. Sometimes, when I am just attending my class, I don't see, and my finger comes to the mouth. So you are going to use it at the school. But let's do something. If any of your friends ask you why you have that on your finger, you are not going to say that you are sucking the thumb, eh? You are going to say that you broke your finger and I put this to fix your finger, all right? I have to give the answers, because if I don't do that, he's going to take out in the school, and I need the patient using in the school. So I have to give them all the tricks. I have to play with them, all right? So you broke your finger and you are using that. And then when I have 1 or 2 months using this, and the patient tell me no, I'm not sucking the thumb anymore. Why? Because there is no pleasure when they are sucking the thumb. When you are sucking the thumb, you are creating a vacuum between the finger that when you try to pull out the finger, is impossible. With the tube, you are bringing air into the mouth so that negative pressure is not produced. And then if the negative pressure is not produced, the pleasure is not the same. So normally after 1 or 2 months using that little trick, the patient say, no, I am not sucking, I don't need any more because I'm not sucking. That's the moment that I can put the appliance. And then I normally work with the T4I, and I can bring from this situation to this situation. All right, in a couple of months. So now the problem is over, and I can continue following up my patient and guiding the craniofacial growth and development. The other problem that I get is with the suture, the patient that has the suture. And normally I don't give an appliance. Normally I give my patient the last suture, the coolest suture, the last development in sutures in the market, which is the T4I. I'm not giving an appliance, I'm giving a new suture, a new pacifier. All right? And then I exchange the pacifier. You bring me your pacifier and I give you the new one. I don't leave the old one. All right? Give me the old one, and actually I have a bag with a collection. I have all types of pacifiers in my office now. But I exchange the pacifier because otherwise the T4I is not going to be as nice as the old. You remember my old shoes? The new ones are not as good as the old ones. It's the same with the pacifier. So I need to keep the old one to be sure that the patient is going to use the new one. But I never use the word appliance. I'm going to give you a new pacifier. In that way, I work, we can go from situations like this with open bites, and that could come to this situation, and the most common treatment is the lingual creep. I mentioned that the tongue is a lady. What is the problem with the lingual creep? I know that some people here have used the lingual creep and has been successful with the lingual creep. And I am not saying it's a bad treatment. It's a correct treatment. The problem with the lingual creep is that regularly, the most common patient that we have to use the lingual creep is because an open bite. And in those patients, the maxilla is totally narrow in the anterior part. So what you do is you take a cast model, you send to the lab, and the lab build up the lingual creep for you. But when they try to put the creep on the anterior part, on the anterior palate, there is no room for the creep. So they move the creep backward to the area of the canines, or even backward, where they have more room. What they are doing? They are invading the space of the tongue. So the tongue start going downward and overpassing the creep, or just pushing the creep and burying the creep on the palate, or breaking the creep. Because remember, you have 17 muscles working together in the tongue. Just if you review. So I prefer to use the infant trainer, which is a more gently appliance with the tongue, and we can come from that situation to this situation and close the bite without any problem. So now the problem is over. I can just follow up and continue guiding my patient in a physiological growth and development situation. So for me, the earliest I can treat a patient, the better. And if you see, I am completely treating the malocclusion in a primary dentition. So what happened now when I have other situations, for example, a crossbite, in this case from a canine to the second molar in the primary dentition, I can treat that situation, and you can have this situation 2 months later. And that's when I start talking about the Planas philosophy. Okay? This is a journal that I have published in the Journal of Clinical Orthodontics describing this technique. Those people that have been with Derek Mahoney from Australia, Derek have talked about this technique because when he read the paper, he said, Herman, you have to teach me how to do this. And So Derek have talked. Let me switch here to the next one, so I can explain you a little bit about this. This is not my technique, all right? I think whoever is up there put me here just to explain how things work, all right? He put me in the same road with Chris to explain the trainer, and now I am bringing the Planas philosophy to you in English, because this guy, who is Professor Pedro Planas, he was in Barcelona in Spain, and he was a very tough guy. He already passed away, unfortunately, but a very, very smart professor. And normally you ask him, why does it work? And he said, who cares? It works. Use it. And they invited, for example, here in the state, Frank Garcia from Tampa. He invited him several times to come to the US and talk here, but he said, Professor Planas, you have to speak in English. And he said, if I want to learn something from them, I have to understand English. If they want to learn from me, they have to understand Spanish. And he never wanted to write a single thing in English. So now I am trying to bring that to English and for you guys to understand. So that's why today, we are releasing my book, that is Early Treatment of Malocclusion, Prevention and Interception in Primary Dentition. So this is my first baby, all right? And what you are seeing in my book, these two babies are my kids. These are my boys, all right? And what I am saying there, I apply this philosophy and all the concepts that I know in them, and now they are 21 and 19, a future mechanical engineering next year, a future computer engineering in 2 years, with a beautiful smile, as handsome as the father. But they are now with no cavities, with no malocclusions, with no TMD disorders, with no periodontal disease. So I did something good. I prevented all of them in there. And that's what I try to transmit in my book. So because I think if I were showing my kids with a malocclusion, it's because this didn't work. All right? So it works, and I did. So basically, if you go to, I will show you the webpage in a minute. But one of the things that I see is that I got a lot of cross bites in my office. And I don't know, it's because as I treat them, they start just chatting around and say, he can treat it. So my colleagues probably are sending those patients to me to test me if I really can treat it, all right? But one of the things with crossbite is that crossbite has to be treated as early as possible. And if you don't treat a posterior crossbite or even an anterior crossbite, it's going to produce a shifting in the mandible, and this is going to become an skeletal problem, which is even worse to treat later. And that has been published in the American Journal of Orthodontics. So it's in your shelf, guys. If you go and review the American Journal, you have all this information there. What happened when I have a baby and I start closing and I get an interference? The mandible is gonna be displaced even forward or laterally just to avoid that interference. So if you remember, I told you that the patient about 4 years old learned how to bite. So at that moment, let me go back, and at that moment, if the patient, when he's about 4 years old, learn how to avoid the interference, is gonna close directly in the crossbite. And when this situation happens, so the patient is closing, then you are gonna start stimulating more growing of the mandible, and the problem is gonna become from functional to an skeletal problem. So I want to intercept that problem before it becomes permanent problem or an skeletal problem. So I use the philosophy of planas. You can see this case, you can see, if you see the facial midline, you can see that this patient is starting to shift the mandible in this direction. And if you see the mouth, she has that crossbite. So if you bring the mandible to the center, to a centric relation in dentistry, you can see that the interference is here on the anterior part. So every time she was closing, she was shifting the mandible to this side. So we release the interference and the patient is able to close by selective grinding. In my book, I explain step by step in every situation how to do the selective grinding, so I'm not gonna talk too much about that. But you can bring, and you see this open bite because the mandible is shifting and doing this. When I bring the mandible to the center, there is gonna be a space here, and I need some development in this area. But the patient had learned how to close in crossbite, and she was going back to the crossbite, even though the interference is not gonna be there. So what I did was just to build up with composite one of the tracks, and just guiding the mandible in this direction, so I create an interference here. So every time she was trying to close in the crossbite, the interference appeared and slide the mandible to the center. And in that way, you can have this situation later with the midlines corrected. And look at here. Look at the space that we have here. Look at how it is reducing. Now it's a better situation on the face. And look at here, totally closed. And if you check the size of this crown, is exactly the same crown, the same size that I had at the beginning. Is the whole dental-alveolar unit developing and just closing that situation and bringing the occlusal plane again to a physiological situation. So there is no problem with those open bites. They are gonna close, all right? Those are temporary. And here you have the situation, everything working well. And then we got the permanent dentition, the mixed dentition, and everything is corrected and everything is developing in a better situation. Then I use a little bit of another functional appliances that they are the indirect planar tracks, that they are some removable appliances guiding to produce a little bit more of transverse development. At that time, I wasn't using the trainer. And we can become to this situation with a very happy teenager, all right? Without any problem and everything developing in a right situation and producing lateral excursions and producing all the problems. So what happened? I have to bring you back to the anatomy and physiology because now you are loving physiology and anatomy. You want to be an anatomist now, from now on, all right? So we were talking that the suprahyoid muscles, the digastric and the mylohyoid, are bringing the mandible down during the opening, and that happened normally. Then when we start closing, we have the medial pterygoid, the masseter, the inferior head of the lateral pterygoid, and the superior head working together, and the medial and anterior temporalis closing the mouth. But on the other side, we have these two pulling the mandible to one side, particularly the inferior head of the lateral pterygoid, and on the crossbite side, we have the posterior fibers of the temporalis and the masseter, the deep masseter, just bringing the condyle backwards. So when the patient is closing and I get that interference, immediately on this side, the lateral pterygoid is pulling this condyle on this way, and on this side, on the crossbite side, the posterior temporalis is bringing the condyle in this way. So the mandible is shifting. And that's what happened. So what we have to do, basically, is on the crossbite side, just try to bring the patient to the center, to a center relation, and identify where we have the interference, all right? And then we can do the selective grinding to reduce those interferences and create the direct track. That's why I always say Planas direct tracks, because I want to talk on behalf of Professor Planas. And in that way, we are sliding the mandible to the center and then to keep the mandible in that situation. So another case that you can see, look at this canine. Look at the cusp of the canine, very huge. And normally we have the interference there in this area, and we have a crossbite here. We created the direct tracks on this side, on the crossbite side, to bring the mandible to the center. Look at the open bite on the anterior part, because I am doing this. So when I am doing this, it's going to open on the anterior part. Don't worry about that. Here you have the direction of the tracks during in a posterior crossbite. And then we have a much better situation. And now, Barry, remember that I told you that your case 1 yesterday is going to close that posterior open bite. Normally, when you are using any functional appliance, this doesn't happen with braces. This happens with functional appliances. When your patient is about 7 to 8 years old, all of us, when we were 7 to 8 years old, we went from primary dentition to a mixed dentition. At that moment, we have the first increase in vertical dimension. At that moment, the mandible and all the occlusion is held by the incisors and the first permanent molars. And the primary molars just remain underneath of that occlusal plane because the vertical dimension increased, and they are preparing to be exfoliated and the premolars to erupt. But the premolars doesn't erupt just like this. They erupt rotating, and they need some room to rotate and erupt. So that's why we have the first increase in vertical dimension to give room to the premolars to erupt. So normally when you are working with a functional technique, regardless the age, if you start a patient when the patient is 15 years old, he or she has to pass through this stage. So normally, at some point of the treatment, you are gonna see a little open bite on the premolar area. And that's totally physiological. Don't worry, it's gonna close, all right? And we came to that situation, which is normal. And this is how you do the selective grinding with an anterior crossbite. But basically, you can get that in my book, but basically what you have is an anterior crossbite like this. What you are gonna do is you are gonna bring the mandible to an edge-to-edge position. Bringing the mandible to an edge-to-edge position is gonna give you some room on the posterior part. And then you are gonna build up the tracks in this direction, from the distal part of the second upper primary molar to the tip of the lower canine. So you are gonna build up the tracks in this direction, and you see that every track is individual on each tooth. It's not a block. Every track has to be individual on each tooth. And then following the lower, you are gonna build up the top one. So if you have that situation like this, you bring the mandible to the center and you build up the tracks on the posterior area. Look at the open bite here. Don't worry about that. Here you have the tracks, and look at the tracks are covering the full occlusal aspect of the tooth. Here are the bottom ones. And then you have this situation. The mandible is going to open because you are bringing the mandible backward, but when it starts sliding backward, the open bite is going to close and the mandible is going to come to a better situation. Here you have the tracts working together. You see how the occlusion is. Here you have the situation. And the tracts start wearing out, so I don't have to remove the tracts. They are on the primary molars, so in the future the molar is exfoliated and the tract is gone, and the premolar has all the situation to come into the mouth without any problem. You don't have to trim out the tracts. And just follow up. Here we need a little bit of transverse development, but the crossbite is corrected and we don't have any problem. And one of the things is that anterior crossbite is corrected, and immediately you correct the anterior crossbite, all the mechanoreceptors in the periodontal ligament are going to receive a different information, and they are going to send information to the brain, and the brain is going to say in the muscles, hey, change your activity. You are working too much. Reduce the work. You are not working. Increase the work, and the mandible is going to come to a new position, and everything is going to be corrected. What happened in this occlusion? Look at this patient, the convexity of that profile. This is the situation with the patient. It's a distal occlusion. This is the bite, a deep bite with a distal occlusion. And just building up with the tracts, we can bring that patient to this situation, improving the face if we are talking about beta faces, all right? Bringing her to this situation. And if I measure this mandible, and this mandible is the natural growth, I cannot show that I produce an increase in growth. It's just the natural growth, the normal age growth. But the muscles are working differently, and they are posturing the mandible in a different position. And I can bring her to this position. So what are you going to do? You have this situation. You bring the mandible to the situation that you want the mandible to be, and then you create the tracts, but in the opposite direction. You are going to build the tracts, always talking from the bottom, from the lower second primary molar to the tip of the upper canine. You build up your tracts, and then you can do a little bit of selective grinding if it is necessary, and then you build up the upper tracts, and you have to build up individual every tract on each tooth. All right? If you work as a block, it's not working very well. So basically, now I can say, how early can I treat a patient? As soon as I observe a problem and I have the ability of making my patient to understand the problem and the treatment that I need to do. So if I have a 2-year-old patient and the patient, I can explain my patient what I need to do and why I need to do, and I see that the child is understanding me and is cooperating with me, I can use any technique. But if I have a 3-year-old patient who is crying in my chair all the time, I am not going to start any treatment because I don't get any cooperation. All right? So it depends. I was trained as a pediatric dentist first, so I have the ability of managing a lot of my patients. All right? Some of you probably struggle a little bit more with kids, and probably will have to wait a little bit more until get more cooperation of the patients. So, but as soon as I get a cooperation of my patient, I can start treating my patient. So look at this girl, beautiful girl, 3 years old, with a normal profile with an Afro-American little girl, all right? But when I see the bite, this is the situation. This was a very nice experience. At that moment, this is a patient that I treated when I was working in Wisconsin at Marquette University. And I just chase my students. And I say, I'm going to treat this case in one appointment. And they say, impossible. That's a surgical case. And I say, all right. So September 20, 2007, the interference was here, all right? What I did was selective grinding, and September 20, 2007, the patient was in this situation. You remember the inclined plane to treat malocclusions? What I did was just respect this point, the most vocal point of the incisal edge, and I just trim this incisal edge in this direction. And then I respected the most lingual point of the lower incisor, and I trim it in this direction. So I create an inclined plane on the incisal edge, and the patient was corrected in one appointment. All right? It's just to understand the physiology. And the patient was going backward. The other question is how late I can treat a patient. Because everybody tells me that I have to treat the patient when they are young, that I cannot treat an adult with functional techniques. And that's not true. The sky is the limit. You can treat adults with functional techniques, and there is no problem. Look at this girl, a deep bite, a lot of periodontal problems. So I didn't want to put braces here with all these periodontal problems. All right? 81, 82. An increase in the vertical dimension with functional appliances. All right? Totally stable. 3 years later, without any problem. Now the periodontist is working on her gums and treating them, but she is not using appliances anymore, but everything is stable. Working with lateral functions without any problem and totally stable. And we went from this situation to this situation in an adult without any problem. The other question is how stable can be a treatment with functional appliance. And I tell you, no relapse must be expected if you are bringing the patient to a physiological situation. If you are treating all the problems around the teeth are going to stay in the situation that you left them. All right? So look at these cases. This is some material from a paper that I submitted recently to the Journal of Clinical Orthodontics that we are working with Derek Mahoney. And these cases were treated with functional techniques. And you can see an open bite when the patient was 8 years old. The patient treated when the patient was 11 years old, 3 years later. And at this moment, the functional appliance was removed and no retainer, no appliance was used anymore from these patients. 14 years later, everything is stable with no relapse. Another case, a 9 years old patient, open bite. 2 years later, the situation improved, totally treated, all right, just waiting for the premolars to erupt. 18 years later, with no retainer, with no appliance, with nothing in the mouth, just working and functioning properly, the case totally stable. So it is possible to finish cases with functional appliances, and it's possible to avoid relapse with functional appliances. So I hope that you have observed, because there is no worse blind person than that who doesn't want to see. I hope that you listen, because there is no worse deaf person than that who doesn't want to listen. And I hope that you will remember. Thank you very much. Just before I answer some questions, if you have some questions, this is the web page where you can get my book. It's just primarydentition.com. All right? In a couple of weeks, you are going to have a link also to this web page on the myofunctional research web page. We are going to create a link. But from today, you can start ordering my book. You have a couple of samples there at the back if you want to see them, if you want to have a look of the book. And if you scroll down here on the right side, you will have a picture of the book. If you click on the book, immediately it transfers you to the order web page. So you can order there, and it's going to be, you have the price. Immediately it calculates wherever you are located, it calculates the shipping for you and will give you the full price. All right? So if you go primarydentition.com, you can get the book, and the web page is today launched to start receiving orders. All right? So it has been a pleasure. I know that probably you have a lot of questions, but unfortunately we are limited with the time. Thanks God I finished on time. So if you have any questions, we can have 5-10 minutes to answer questions. If you have any question. Yes, Barry.
Talk about the clinical technique for doing the planus tracks. Talk about the clinical technique for doing the planus tracks.
Yeah. Now at this moment, normally I build up them directly in the mouth. But for you who are starting, I will recommend to use the indirect technique. What I do is I build up the tracks in the lab, and I bring them ready to bring. So basically what I use is I build up in the lab the tracks with Duralite or any other acrylic that I can use in the lab. And then I create a tray, like a splint, and I bring that tray to the clinic, and I fill up those areas with the composite, and then I glue the composite. In my book, I explain the indirect technique, and also if you go to that 2003 paper in the GCO, I explain the technique, the indirect technique as well there. All right? Yeah. Yes.
When would you use the planus track technique versus trying a trainer?
In a lot of cases, I combine them. For example, if I have a class 3 or a crossbite with tongue thrusting that you may have, or if I see that I put, for example, the I3, and the patient is using during the night and is holding the mandible here, but during the day the interference appear again, and I have that problem, so I put the tracks plus the I3 at night, and I combine the techniques. I combine a lot of techniques, all right? For me, when I am designing my treatment, I always think like fixing my car. I cannot fix my car with one tool. I have to use a lot of tools. So every time I can hear somebody with a different technique, I try to understand the technique and how applicable it could be in my cases. And I combine a lot. For example, if you have a severe disc occlusion, I build the tracks to bring the mandible a little bit forward, and then with the trainer to help the tongue to come to a better position. So you can combine them without any problem. Right? Yes.
For the patient with class 3 occlusion and a mixed dentition, would you band his first permanent molars so they do not super erupt?
If you are still in mixed dentition, build up the tracks on the primary molars. Normally, if you have a class 3, they are not only mesial occlusion, but they are also deep bite. So if you build up the tracks on the primary molars, you are going to give the opportunity to the first permanent molars to develop more and to produce that increase in vertical dimension that didn't happen before. So there is no problem. Just leave the first permanent molar free with no tracks, and they will develop exactly the same as I show you with the second primary molar.
Do you use this same technique for children that are severe bruxers that have ground their teeth down? with the track, build-ups there.
Yes, yes, I use that because normally, and in those cases even more, you put the trainer in. Because I need to relax the deep masseter in those patients. The deep masseter is causing the problem. So build the tracks to bring them to the normal vertical dimension, but use the trainer to relax the deep masseter.
When you're starting a young child with the early trainer for infants, do you start them just chewing into it during the day? Do you gradually work them into it? What's your protocol?
I know that in the webpage and all the literature for the T4I is saying that it start a little bit, and start increasing. Normally, I go directly and I ask the patient to sleep with the appliance. I don't start slowly. I aware the parents just to be sure that they wear the belt. So because the first 2 or 3 weeks, they are going to lose the appliance during the night. But I am seeing that they accept the appliance without it. As far as my kid understands what I want to do in her or his own language, they cooperate very well. So I spend a lot of time explaining what I grab the appliance, I show them exactly every single part of the appliance and what it is doing in the mouth and how it's going to play in the mouth. And if they understand me, they use the appliance.
Herman, you explained to us how changing muscle function gives us results with functional appliances. Is this true also with a trainer? And talk about this protocol of only 1 hour a day and what's going on with the 1 hour and then what's going on with sleeping.
Oh yeah, thank you for reminding me about that. What happened? Normally the trainer is advised to be used or is indicated to be used approximately 8 to 10 hours during the night and 1 hour during the day. What happened? Why this protocol? When you are delivering an stimulus on the mouth for 6 continuous hours or more, you produce an effect. So the simplest way for using the appliance is to use at night because I guarantee that my patient is going to use at least 6 hours. Normally we sleep on average 7 to 8 hours. So at least my patient is going to use 6 hours continuously and will have the stimulus for that time. And also at night, if you remember, is the highest level of release of growth hormone. And if we have the highest levels of release of growth hormone, I can expect the better response. And also, if you remember, Profit demonstrated that the eruption and the development of the dental alveolar units occur at night, not during the day. So if I am giving the chance to these dental alveolar units to have the appliance guiding them where to develop and where to go, I will have the best moment for the whole development. Now, so that's why we recommend to use the appliance at night when sleeping. Now, we also recommend about 1 hour during the day. What I have observed is that the patient that use 1 hour during the day is just wearing the appliance and is sending a message to the brain saying, remember, this guy is using an appliance. So what I have observed is that the patients who wear the appliance during the day at least 1 hour, they adapt to the appliance to be using at night quicker than the patient that doesn't use the appliance during the day. So normally, the patient using the appliance during the day, after 2 or 3 weeks, is sleeping with the appliance with any problem. The patient who is not using needs 4 or 6 weeks to adapt to the appliance. Actually, a lot of my patients, after I see that they are sleeping during the night with the appliance, I say, you don't need to use the appliance during the day anymore. And I just release them for using the appliance during the day, and I am getting the same results. So basically, the 1 hour is a reminder for that. All right?
tell them to keep their lips closed for the 1 hour while they're wearing it. Activating facial muscles. We tell them to breathe through their nose. We tell them to hold the tongue up onto the roof of the mouth. Most of these things they can't even do at night when they're swallowing, and they know that. I mean, one of the most common questions I get from mothers is, well, why does he have to wear it at night? He can't do any of those exercises at night. Now, and then just
It's an unconscious effect.
let me finish
They
this
don't
one.
they don't see that effect at night. So what happened? The tap, even though we are sleeping, the tap is stimulating the tongue to stay in that position. And every time you are swallowing, even though you reduce the frequency of swallowing when you are sleeping, you still swallow. And you have to close your mouth when you are swallowing. So the patient is not seeing that this is happening, but it's happening. So if you are recommending the patient to do that exercise during the day in that hour, it's good because you are sending a reminder to the brain that they have to do that at night, even though they don't see it. Because you need to swallow at night.
Many mothers ask me, will this work better if we wear it more than 1 hour a day?
I will say wearing at least 6 hours during the day is going to be very uncomfortable for the patient, for the kid, because they are going to be at the school with the appliance.
No.
They cannot talk.
No, but let's say, they go, well, if I wear it 2 hours, will I get done sooner? Well, if I wear it 3 hours?
I normally recommend to increase the time during the day is in mouth breathers, because in the mouth breather is a weaker muscular activity, and I need to potentiate that stimulus. So normally in mouth breather, I recommend to use 2 hours during the day to keep that message to the brain more active during the day. But in other patients, or in patients that I have a severe deep bite, and I am seeing that the patient is losing a lot the appliance during the night, I increase the time during the day. But the big effect, I don't say you are not producing any effect during the day, but the big effect is going to be at night, because you have all the environment helping you to produce the effect.
Then from a management point of view, do you think would it help to have them do at least a half an hour of that time just before they go to bed, so that they've
Well,
accommodated?
normally
to
I recommend to wear the appliance immediately after supper, after dinner, not just before going bed. I normally ask them, you have supper, then you brush your teeth, you floss your teeth, and you wear the appliance. In that way, they are going to wear the appliance at least 1 hour before going bed. Yes, I had a question here.
Most people's answer, does it have to be consecutive 2 hours or an hour? Can it be like 20 minutes here, 20 minutes there?
I don't see a real difference breaking down that hour. But I cannot say, yes, you are producing a different effect or not. I haven't seen any difference. I will say probably, at this point, I will say probably it doesn't matter. Yeah.
Patients that complain about, or mothers say, they start out with it in their mouth, but in the morning, even after 4 or 5 weeks, they're still spitting the appliance out.
Look at the lip seal. Probably the effect on the mentalis is not that one. For example, if you are using a T4K, you switch to a I2, that you can produce a stronger effect on the mentalis. And probably it's because the patient is not producing the lip seal that we need. And the other trick that I use the tape on the lips. Those patients that they continue losing the appliance, I ask them to put a tape and produce the lip seal.
I asked them to put a sweatband around their head there. But
Oh, yes. It's the same. Just try to hold, because some patients just drop down the mandible too much when they are sleeping, and they keep the lips on seal. So I try to produce. I use the tape, but that way it's also. What kind of tape? Oh, I use the surgical one that is not creating the same that they use in surgery, the transparent one with little pores that they use in surgery. The transparent with pores that they use in surgery, normally like bands in surgery, just that's the one that I use. One that is about 1.5 or 2 inches wide. All right, thank you very much. We have more things to cover, but thank you for supporting me 2.5 hours and talking a lot of anatomy and physiology, and you are still here. Thank you very much.